So I'm just going to get started by welcoming everyone. Welcome back to our FSHD University Educational Webinar Series. We're here to keep the learning going. We're working really hard to give you, who are families, an arsenal of knowledge so that you can be your own best advocate when it comes to your care and empower you to better understand research like today and the role that you can really play in accelerating therapy development. So that's what the purpose of our FSHD University is. And today, from our research department, we welcome Dr. Tina Duong from Stanford University, who will speak to us about early onset FSHD. She's going to provide us with an overview of the current understanding. And I read this, so I just want to make sure this is right. Provide us with an overview of the current understanding on the multi-organ impact and the disease progression based on the published literature of multiple natural history studies. I'm hoping I got that right.
Yeah, perfect.
And then just to introduce you, Dr. Duong is a research physical therapist at Stanford University with over 15 years of clinical experience in evaluating, treating, and supporting our patients with neuromuscular disease. Her clinical and research interest is in developing and refining outcome measures in neuromuscular disease, as well as understanding the impact of exercise and physical activity, huge topic on all disease physiology and the quality of life itself. She's a part of the Stanford NMD care team and also a part of our recent CTRN expansion, which is exciting as well. So without further ado, welcome, Dr. Duong.
Great. Thank you so much, Beth. And thank you, June. It really is an honor for me to be able to speak here. FSHD is very near and dear to my heart because of many things, but I think I mentioned earlier, it is a disease group that keeps you very humble because it's ever so changing and you think you know something and you don't. So let me go ahead and share my screen. Please let me know if I was successful in it. Can you see it okay?
Yes. Excellent. Thank you.
Okay.
Oh, it's
Great.
funny. It's also
oh, the caption?
Yeah, the closed caption. That's amazing. Yes, excellent.
I actually learned that. It's a PowerPoint feature. I learned it just to be, inclusive, that you can do closed captioning. Now, if you ask me how to do it, I don't know how to do it now, nor do I know how to shut it off. So now everyone's stuck with captioning every time I do a presentation.
That's fantastic. Thank you.
Yeah. So anyway, like Beth was saying, I'm going to talk to you today about early onset FSHD. There is a body of literature. There's not a ton. So I'm just going to give you a taste of it. And I know that everyone here loves to ask questions. So hopefully I can answer some of those or at least tell you I don't know. But I thought I'd kind of start everything with kind of a spring feel, because most of you probably are under snow. If you're in the US, 3/4 of the US is under a lot of snow or ice. So, I thought I'd give a little spring inspiration because hopefully it is just around the corner. So we'll just dive in. Let me see, this is not working. I always like to give a roadmap as to what you should expect in the next hour. And so for our roadmap today, I'll talk about what's the need. Why do we really need to even understand early onset FSH if we understand already the classical form? Then by doing that, I'll do a quick overview of just the classical form of FSH because most of you know about it and probably are tired of always hearing about it, especially if you have early onset. So I'll try to highlight the differences between the two throughout the talk. And then, of course, I'll do a review of literature of the primary groups that have done some natural history or trying to understand the natural history of early onset a little bit better. Then, of course, we can't talk about early onset without some of the extramuscular manifestations. And I'll mention those because that's going to be very important in your ability to advocate and for care and care management. And then lastly, I'll just give a quick description about some of the future directions that we need to go as an early onset group on the road towards clinical trials development. So that being said, why does this matter? Okay. First and foremost, we're all here because we want to see some kind of clinical trials that will change the trajectory of treatment, right? And so to do so, we know that in other neuromuscular diseases that have had treatment, one of the most important things to understand is how does the disease evolve? And so we know that early onset has a different pattern of progression or trajectory than the classical form. So we need to understand that better. And then secondly, we need to understand what outcomes or measures that will be meaningful to change to you as patients and most sensitive to measure change in treatment. And so we only learn that through the natural history studies. Natural history studies are a good way for us to not only understand how the disease progresses, but how these outcomes will impact and what is most likely to change. And that's going to help industry to de-risk the trials themselves to make them more likely to invest in early onset. And that being said, we also are able to understand the different trajectories within individual patient and patient populations. That's important so that we understand what we should expect if there's a treatment, if there should be a change in a patient population that's more slow progressing. So should there be a plateau and you see there's an upward trajectory, or if they're faster progressing, and what that delta or that change may look like. And then most importantly, right now, it's for standards of care and care management. Because as we're looking for the future, we need to live for today, right? And so we don't want in a care model to have constantly living in a reactive care model. We want to be proactive and even better yet, anticipate. And we can only anticipate by knowing the natural history. But at this point, we can be a little bit more proactive by understanding some of the characteristics that are part of early onset, so that as patients, you can talk to your doctors about diagnostics and evaluations for certain organ systems that may be more likely to be impacted because you have early onset. And the purpose in this is to give you data-driven answers, right? We are more than happy to say we don't know, but we want to be able to give you answers that are based on what we do know. We can only do that by understanding the natural history better. And we know the clinical manifestations different. So what is the progression rate? What is the different trajectories? And it's very important to understand what this looks like throughout the disease spectrum. And of course, the extramuscular impacts, and then different muscle patterns of involvement. So this is my area of, or my soapbox, right? Because this impacts exercise. It impacts how you exercise, what exercises you do, and to do it in a safe manner. Because everybody can exercise, it's a matter of how. And we don't want you not to exercise because a sedentary lifestyle has all sorts of comorbidities that we want to avoid, but we also don't want you to injure yourself. So how do you safely do it? And then, of course, with physical therapy, many of you are very involved in exercise and physical therapy, and this is a collaboration between the therapists, physical trainers, and I know the FSHD Society is so great about advocating for this. And so understand the different muscle patterns will give advice. We're able to give better advice on equipment that's needed, maybe different assistive devices to help you be more autonomous, bracing that will make you safer in some of your mobility, outside or your exercises. And then of course, biomechanics. Biomechanics is key to being able to be active and doing it safely. If there's a will, there's a way. It's just a matter of sometimes you have to be a little bit more creative about it. Because the primary care here for both you and I is to improve care outcomes, and particularly for you to maintain an active, healthy lifestyle, regardless of what phase of the disease you're in. Okay. Generally, when you're looking at FSHD, we're really looking at a spectrum of of disease. And there's always the question: is early onset different than late onset? It's just a spectrum. And so today we'll focus on the early onset. And you'll see historically it's been described as infantile onset, juvenile onset. In purple here, you'll notice that what we talk about early onset is either the infantile or juvenile onset form that has been referenced before. And we know that with this early onset form, the disease is more severe. There could be faster progression. And of course, there's extramuscular manifestations. For the later onset or the more classical form, I'm not going to talk about it much today, but typically the diagnosis is later in the teens. It's a milder symptomology or even asymptomatic at times, and it's much, much slower progressing, right? So quickly, I'll go through some of the classical forms so that we have a reference point when we're talking about early onset. The prevalence here is 1 in 15 to 20,000. And typically patients who have the classical forms diagnosed in their teens up to adulthood. And the initial symptoms is a varying amount of initial symptoms, but a lot of it is scapular weakness to begin with. And then there may be mild facial weakness, but we also noticed in our early onset study that people have a hard time with recall bias in facial weakness. Because if you've always had weakness in your face, how do you know that was any different than anyone else? So it may not always be seen. And then lastly, other people have reported that when they're reflecting back, that maybe when they fall asleep, people have noticed that, oh, their eyes are slightly open whenever they're sleeping. So these are signs of facial weaknesses that may lead to a diagnosis, right? And like I said, the classical form is slow progressing, and the loss of ambulation is not really high. There's about 10% of those who actually lose ambulation. And the age of onset is not necessarily correlated with severity. And you'll notice in the next few minutes that that's a little bit of a different story when it comes to the early onset form. And males are more severely affected than females. In the early onset forms, different people say different things, but it seems to maybe be flipped, where females may be more affected than males. So that is a question that's still open. And then we talk about de novo mutations. So spontaneous mutations. In the classic form, that's 4%. And in the early onset form, that's 46%. So dramatically higher. And then in the extramuscular manifestations, you really don't hear much problems with the cardiac respiratory difficulties like you do in the early onset. And of course, there's really not much contractures because of the slow progression. You don't have that muscle imbalance that may lead to tightness and contractures and spinal deformities as much as you would see in the early onset form. Okay. That being said, what is early onset? So I think this is pretty accepted on how early onset's defined. It's typically defined as facial weakness before the age of 5 years, or scapulohumeral or shoulder weakness before the age of 10 years. And the prevalence here you can see is much less. The classical form is 1 in 15, 20,000, while this is 1 in 200,000. Okay, so much rarer. And 5 to 10% of those patients who have FSHD will probably have the early onset form. Okay, difference here is facial weakness, or one of the earliest signs. And what is typically seen, because this is earlier on, they may see that in babies having difficulty with feeding or latching. The average age of onset you can see is dramatically younger. Average is 2.8 years of age. And age of onset can potentially serve as a prognostic marker of disease severity. And multiple studies are validating this, this hypothesis. And of course, the severity and the sequence of muscle involvement varies from that of the classical form. We see that there's smaller variability in the severity of muscle wasting. And patients typically become non-ambulatory or need a wheelchair by the second decade of life. And I think I said this earlier, there's increased spinal deformities just because of the severe muscle weakness. And there's better genotype-phenotype correlations, but they're, of course, still imprecise. There has been some studies looking at associations with a smaller number of repeats with increased severity. Okay. Now I'll just directly go into one of the studies that's done in Radboud University outside of the US. This is a single site cross-sectional prospective study. So what this means is this takes a point in time in a patient's life, and they are assessed. And this is what you're seeing. There were 28 patients enrolled. The inclusion was the early onset, as I described earlier. And what was interesting about this study is they tried to compare early onset with the classical form by looking at early onset here, age matched classical form and the duration of having the disease. And you'll notice that there is a distinct difference. You'll notice in the next few minutes, I'll talk a lot about the CSS, or the clinical severity scale. And it's a scale that probably many of you have gone through. If you've gone through clinical evaluations, they look at facial, scapular, pelvic, weakness. And so you'll see here there is the statistical significance between the onset of, the clinical severity score. The higher the score, the worse in this situation. So you can see early onset has a score about 8, while the age match is about 5. And you could see this as this is a nice visual that gives you an idea of how disparate it is between those two. Then when you look at muscle strength, the same kind of applies. Muscle strength is different. The lower the score, the weaker. So this is an average sum of muscle groups. And you notice that the early onset has about an average sum of 30, while the age match is 40 something. While you put into combination of how long they've had the disease, it's pretty equitable. Okay. Then it gets a more dramatic when you look at wheelchair dependency. So here in this study, patients were needed a wheelchair at around age 30. Those who were age matched did not. They did not have any. And then it's almost 30 years later for those with a duration match in the classical form before they needed a wheelchair. So you could see that is pretty dramatic difference. We already talked about the de novo mutations. And then here's the FBC. You can see here in percent predicted that, the classical form is 79, 78% predicted, while FBC is only 50 something percent. And of course, going back to spinal deformities are quite prevalent in early onset compared to that of the classical form. Now we look at age of onset, which is interesting about this study because what they found is kind of a bimodal distribution here. Between the ages of 0 and 2, there was a peak of onset of symptoms, as well as 8 to 10 years of age. And so when you look at this, what they found was patients who were less than 8 years of age had a more homogeneous, meaning the same presentation or similar presentation of symptoms, and increased extramuscular or systemic manifestations. While those who were diagnosed between 8 to 10 years or a later, I guess you could say juvenile onset, they had increased heterogeneity in their scores and decreased amounts of systemic features. And I'll highlight that here and kind of break it down on the table on the right. So you could see the clinical severity score that we talked about earlier, that the earlier onset is 9 and 5. So like I said, higher is worse. So that you could see that on average, the clinical severity score is higher for the earlier onset. But what I want to highlight here is that if you look at the range, the early onset's range is much smaller compared to the later onset, which encompasses the entire range of the scale. So you can imagine it would be much more difficult to distinguish differences because the variability is so great, right? So we need higher numbers to really truly understand how this is presenting. Then you look at wheelchair dependency, and 65% of those who have the early onset under 8 years of age needed the wheelchair, while only 36 in the later onset. And then when you look at the systemic features, the primary difference here is hearing loss. 29% had hearing loss who was diagnosed under the age of 8, while only 9% had hearing loss who were diagnosed above the age of 8. Okay. So what we know is that the age of onset from this study directly correlates to the severity of the disease. So every disease-free year is important to disease severity. So I know that what you're thinking, disease-free year, what does that mean? It's so subjective because that's when I see symptoms, right? So that's a discussion that I'm sure we can have much of, because when we were going through our studies, we definitely did. Now, I'll talk to you about a study that's near and dear to my heart. This is a study that is done through Synergy, my previous employer and workplace in Washington, D.C. We are a neuromuscular network. And so we did this for early onset, which is sponsored by FSHD Society. We did this with 12 sites. And this resulted in a sample size of 52 patients. So you could see it being rare. It was not an easy study to recruit a ton of patients. So we needed a lot of sites for this. It is also cross-sectional. and prospective. So again, a snippet in time of what these patients look like. We had more females enrolled in the study than the previous one that I mentioned. But one of the things that I want to highlight here is that we took a lot of time and effort in deciding how we want to approach this early onset study. We referenced the Tawil's work in the classical form FSH and their natural history study. We purposely talked to I purposely talked to the PTs who were pivotal in this, including Sri Pandya and Wendy King, who designed the natural history, so that we can look at the measures and perform the outcome measures in a way that's comparable when we're looking towards the future, right? Because being a researcher, you think about today, you reflect on the past, and you're looking for the future. So this is why I never know where I am in space. But that being said, I think this is a uniqueness about this study that's crucial. That being said, if you guys can give me a few moments, this is the late Dr. Robert Leshner. He's been pivotal in my career development, and he was pivotal in this study. I remember him coming to my office and saying, Tina, we need to do this. Let's plan this out. He is a mentor to me, a great educator, and one of the best neurologists you could find. And I'm so grateful that I have had the experience to work with him. He's always been such a supporter on things that may even be crazy and others didn't support. So I would like to thank him for this study and thank FSHD Society for allowing me to do this talk in such a timely manner, because it really allowed me to reflect on so much conversation I had with Dr. Leshner about this study. Okay, so now we'll go back to the findings. What we found here that was published by Dr. Jean Ma in 2018, we also looked at the clinical severity score. And you could see in this patient population, the number or the score is lower than that of the previous study. I think the previous was a 9 or so, ours was a 7. But what I want to point out here are the differences in involvement. 100% of patients had scapular involvement, followed by facial involvement, then upper extremity involvement. Not a surprise to any of us, right? Then you move down to the lower legs, and this surprised me a little bit. There were more distal leg involvement before there was proximal pelvic girdle involvement, okay? We also did time function tests, and this includes 6-minute walk tests and the 3 stooges of time function tests, the supine to stand, 10-meter walk, and stairs, right? When we looked at 6-minute mean distance, there's about 490 meters that the patients were able to complete. And, this sounds like a lot, right? But then when we looked at it based on the average, 42% were 2 standard deviations below the average. So, it's good, but it's not great, right? What we also found was the older age of enrollment was associated with a higher clinical severity score, meaning worse disease, right? And slower time function tests, also meaning worse disease. And this was statistically significantly different. We also looked at the D4Z4 repeats, and we found that it was not associated with sex, race, BMI, or motor performance. Okay, but we found that those who were underweight, that was more associated with muscle strength in looking at QMT and MMT for the muscle groups. Okay, so what was interesting here, we did find that on the onset of symptoms correlated with disease severity. However, we found that the onset of facial weakness was most highly associated with symptom severity compared to just scapular overall. It was significant in a lower clinical severity score, slower time function test, and lower manual muscle test grades. What we found was with each year of increasing age of onset, it was associated with a 0.7 decline in the clinical severity score and a mean decline of 2.6 on manual muscle testing. Now, I'll dive a little bit deeper into some of the functional and motor outcome measures, which is my toolhouse that we didn't publish in this paper. a reminder to you, these are the study motor outcomes that we used. I mentioned most of these. The only thing I want to mention here is the manual muscle tests that we added. We looked at the MRI studies and decided to add some muscle groups to tests that were early, or that showed early signs of weakness in the MRI studies, including serratus anterior, the lower trapezius, and rectus abdominis, right? And the interesting thing here is I think a lot of it's also compensation and different ways of testing, but we didn't find that it added any more to our knowledge about strength than other muscle groups. It also wasn't the early indicators of change that would tell us about clinical disease severity. So that was a hypothesis that we threw out that was a little bit different than the previous study. But now we know we don't need to add that to your burden whenever you come see us for an evaluation. We also did pulmonary function tests. In addition to the other FBC and stuff, we also looked at respiratory strength measures. That includes MIP and MEP that I'll talk about later. And then quality of life measures, including the PEDS-QL and the DASH, which is a disability, a patient-reported scale that looks at arm disability, okay? I'll talk about joint range of motion first. What we found, we didn't really find any major contractures. And if there were contractures, that was mainly because they're non-ambulatory and now it's more positional contractures rather than disease-based. We looked at active range of motion and passive range of motion. So what I mean about passive range of motion is someone's able to help you move your arm throughout the range of motion. Active is your own muscles have to move it through that range of motion. The reason why we assessed both, which hasn't typically been done in other studies, is when I see you in the clinic, I want to know actively how you're able to move how much range of motion you can move actively, because that's related to activities of daily living, the ability to wash your hair, feed yourself, all those kinds of things. So when we looked at that, we looked at shoulder abduction, which is the ability to bring your hands out to the side of your body. We found that there was about a 58-degree difference in shoulder abduction between passive range of motion and active range of motion. Highlighted in yellow here, you can see that's the active range of motion. So imagine that's how high someone's able to use their muscles to raise their hands, okay? And we found a similar result when looking at shoulder flexion, and that's the ability to raise your hand in front of you. There was about a 53-degree difference. So passively, they're able to raise their hand all the way up to 168 degrees, but actively, indicating some muscle weakness, they're only barely able to raise it above shoulder height, okay? So both that shows some functional decline there from the upper limb perspective. When we dive a little bit deeper into manual muscle testing, we found that the majority had early facial and shoulder girdle weakness, over about 80%. And 21% of our population was non-ambulatory, okay? And then when we looked at the muscles that were most affected based on manual muscle testing, showing 2 to 15% of normal strength, we found that the abdomen, the abs, and the upper limbs were most affected. But despite this upper extremity weakness that we saw, 50% of the people still were able to get their hands over their head. And why is that? It's because you guys are fantastic about compensation and being able to use momentum and other muscle groups to get your hand or your limbs where they need to go. When we looked at the lower extremities, what was interesting, we found some quadriceps sparing. So 43% were normal. And then the muscles that were the weakest, between 10 to 21% of normal, were the pelvic girdle muscles, the knee flexors, and the ankle plantar flexors, okay? That being said, we're gonna dive into this a little bit deeper. From a manual muscle testing perspective, many people talk about how it's subjective, is not as objective, but clinically, we use it for a functional evaluation. So I divided this group into 3 different scenarios. A 0 to 2 on a manual muscle testing scale means you can activate your muscles, but you can't really move it against gravity. So you can move it in a gravity eliminated position, we call it. A 3- to a 3 means that your muscle's strong enough to move against gravity, partially or through the entire range of motion, all right? And then a 4 and a 4+, anything beyond a 4, means that you can move it throughout the entire range, and I can add some resistance to the muscle testing. What we found when we compared different muscle groups to the 6-minute walk test was that the ankle dorsiflexors were the best ones to differentiate 6-minute distance. And that is actually really important to know, because here, when we divide into these three groups, the ones that barely have any activation, which is on the far left here, the ones that have partial active range of motion, and then the strongest one, none of the blue blocks overlap each other. So that's really good and surprising that we didn't expect out of this study. We looked at other muscle groups that were shown to be affected, including the knee flexion. And you could see here that doesn't really differentiate well because of the overlap of the blue boxes. Then we also looked at hip extension and hip flexion. What we found is that that also wasn't the greatest in differentiating how far you're able to walk. And we found that with hip flexion, most patients needed at least anti-gravity strength to do the 6-minute walk test. And lastly, we looked at knee extensors to see if it was a good predictor for distance as well. And as you can see, it's one of the poorest predictors. And that's partially because we have 43% of quad sparing that I showed you earlier. Now going to respiratory assessments, because that is something that came up to be more prevalent in early onset. We found that muscles were more involved. And you could see here, there's FVC all the way down to the respiratory measures of MIP and MEP. MIP is the inspiratory, how hard you're able to inspire, and then MEP is how hard you're able to expire, okay? And you could see these are based on percent predicted. As you go down to require more muscles for breathing, especially with MEP, that the percent predicted goes down greatly. However, that being said, this is also a difficult one to study because the range is so great. People range from 13% to over 100%. So even though respiratory is an issue, there's such heterogeneity in it that it's difficult to interpret in this small group. And then we also look at Beaver sign, because we know that's a classical sign of FSH. And we didn't find associations between the Beaver sign and abdominal strength, which was surprising to us. And also there was no association with FBC or 6-minute walk test with the Beaver sign. And then of course we wanted to see how well all these things correlated to one another. And we found some significant correlations here. We found like the total upper extremity muscle strength was highly and significantly associated with the DASH that I told you about. The 6-minute walk test also was significantly correlated to the clinical severity score. And then when we looked at manual muscle testing, ankle dorsiflexion was our superhero here, which showed very significant correlation to how far you're able to walk. And then what I didn't mention before was a quantitative muscle testing. When we looked at knee flexion and knee extension, that knee flexion most correlated with how far you're able to walk on the 6-minute walk test. So in conclusion, for this motor aspect of the Synergy study, we found that strength measures were a good construct, showed good construct validity with the 6-minute walk test. Patient-reported activities of perception using the DASH survey correlated well with upper limb strength scores. PFTs need to be further investigated with a larger cohort. And of course, we need longitudinal studies to assess sensitivity, minimal detectable change, and meaningful change. All right. So now I'll go to the extramuscular manifestations, which is less of my area of expertise, but definitely cannot not mention it when we're talking about early onset. Chen et al. Did a review paper looking at early onset, and you could see highlighted in red are some of the areas that were more that were different from the classical form. And so we'll go through some of these in the next few minutes. The first one's hearing loss. Okay, in the classical forms, there's not much hearing loss that's seen, but there's sensorineural hearing loss that impacts about 40% of patients who have early onset, and it's usually with the high frequency that there's a loss. It's usually detected between the ages of 0 and 7 years of age. Why this is important is because it's going to impact language development and social development, especially for young kids. So that being said, it is really recommended to have hearing evaluations and speech evaluations because this may impact social function and development in the young kids. Then we talk about respiratory. And what we found was that 8 to 11% require some kind of assisted ventilation compared to less than 1% even, or 0 to 7% in the classical form. Right. And so here the recommendation is there's annual monitoring of PFTs, in particular if you are using a wheelchair or if you have scoliosis or any kind of spinal deformity. All that being said, make sure that the interpretation for PFTs are a bit difficult because of the poor lip seal, and the need to seal your lips is crucial in obtaining good PFT measures. So this may be a discussion that you may need to talk to your care providers, whether they use a mouthpiece or a face mask to do your PFTs, depending on how strong your lip muscles are. Okay. Then we talk about brain dysfunction, and this is rare in the classical form, but in the early onset form, there has been some genotype phenotype correlation seen in the repeat frequency to hearing loss, intellectual disability, and epilepsy. Some of the initial signs seen in early onset are the extramuscular hearing loss and brain dysfunction. 8% of people who've early onset have epilepsy, which has been directly connected to intellectual disability, and 15% have a developmental delay. So the recommendation here is if you're diagnosed with epilepsy, to follow the normal standards of care of having EEG and seizure recognition and safety education. Then we look at retinal vasculopathy, okay? So this one, in early onset, 37% of people are impacted by this, and it may progress to Coats disease, which is a retinal detachment and could lead to blindness. In early onset, 6% have vision loss, compared to less than 2% in the classical form of FSH. The recommendation here is to see an eye doctor or a retinal specialist. They should do a dilated eye exam. And you should tell the eye doctor that you're at risk for a retinal blood vessel abnormality, so they can check that in particular. Now we jump to the heart. The heart has less manifestations, but in early onset, there's more. The prevalence here in the early onset, about 9% of those who have early onset have some kind of abnormal EKG. The recommendation here is to have a baseline with regular follow-up for early onset. Well, in the classical form, there's usually an absence of cardiac signs, and so there's no need for cardiac screening unless there's a clinical need for cardiac screening, but that's not expected. So what are our thoughts here? Based on all this, is early onset more severe? Does it progress more rapidly? Does it progress because you've had the disease for longer? These are the questions that are out that we have yet to answer. And then also some of the theories of why early onset may be more severe is because of the role of DUX4 in muscular and nervous system development. Its role in it may impact the ability for muscles to get stronger in the development of the central nervous system, hence the extra manifestations that we talked about. So that being said, your care approach is a little bit different if you have early onset. You definitely need more of a multidisciplinary team. Right? I really like this kind of model. You'll see this a lot in neuromuscular, where the patient's right in the middle. And it requires a coordination of all the multidisciplinary experts, right? First off, you should see a genetic counselor for the diagnosis and confirmation that it is actually early onset. Physical and speech therapy for the reasons we talked about earlier, possibly orthopedic if there's any risk of scoliosis or spinal deformities, epilepsy, and pain control. I want to mention pain because that is something that is reported quite a bit in FSHD, and we do refer patients to pain clinic to manage that because that could really impact your quality of life. And of course, hearing assessments, pulmonary care, and sleep studies if you're having some difficulties with breathing at night, ophthalmology, and then of course talk to your care team and the neurologist who's taking care of you about treatment options and what's coming up next in clinical trials that you may be able to be a part of. But all of that being said, it's under this umbrella of the need for standards of care. It's absolutely crucial for drug development. As we're studying other diseases, we are recognizing that differences in standards of care adds noise to what we're seeing. So if everyone has similar standards of care, it eliminates the variability in what we're seeing in changes of some of these outcomes. And so that's something I would like to emphasize, that I think we're lacking in early onset that we need to spend some time on. So now I'll wrap up a bit. What we found, overall, there's a higher risk in decline in function, systemic manifestations. We need standards of care. And, ooh, what happened? And for clinical trials readiness, that's really weird. We need patient registries. We need a natural history study, and we need to understand outcomes a little bit better. We need to understand, and then we also need to establish the standards of care guidelines. Okay. Sorry, my last slide went crazy with the animations. All that being said, I really want to thank you. This is really quite a privilege to spend this time to give you an overview of early onset and some of the work that I've done earlier on in my career, and thank the FSHD Society for giving me this time. So I will exit out of here and take any questions.
Wow, thank you so much, Dr. Duong. Whew. A lot of information packed into just a few minutes.
Yeah.
It's fantastic. That being said, we do have a few questions, and I will just remind folks, if you do have questions for Dr. Duong, please put them in the Q&A section, not the chat section of our little Zoom window here. First question that we have, and it came early on when you first started speaking, so it may have been answered, but I don't think it was. Can a late onset family have members that actually get an early onset FSHD as well?
I would want to say yes, but I think, the better person to ask would be a genetic counselor, or, I mean, I can't say that I know that for sure. As I indicated before, there's 46% de novo. And so there is a possibility, but I don't know the linkage between a late onset having an early onset. It's not with the repeats that are seen.
Right. Okay. And that kind of leads into our next question that we have here is, did you look at, or is it known any, as far as the D4Z4 repeats and symptom severity, is there a link between the two?
So in the study, the Synergy study, we didn't find a link between the two. That actually was something that we struggled with a little bit, because our hypothesis that we would find that. In our small early onset study, we did not find that to be the case. There is some linkage between the smaller D4Z4 repeats that's done in studies by Chen, that looked that there was more severity in the extra manifestations, like the brain dysfunction, but not necessarily the motor dysfunction or the functional outcomes.
Very good. And this actually even leads into this question. Erica was wondering, is there a linkage between how long FSHD is in the family and if it worsens with each generation? She says, I'm a first generation FSHD patient and curious if early onset is less or more likely if I were to have kids.
I mean, that's a good question. I don't want to answer something I don't know. I don't think so. But as you saw in the Radboud study, is that the longer duration, the more severe the symptoms, just because it's not just about the progression of the disease, but now you have compounding factors, right? You have muscle imbalances. You're not able to work the muscle. So you maybe have some muscle atrophy that is on top of the disease that results in decreased function with a longer duration of disease. And we see that as a kind of an umbrella on top of a lot of neuromuscular diseases with longer duration.
Right, that makes sense. And here's something that's in your wheelhouse. What type of exercises or rehab are recommended, and at what intensity?
This is so specific or
Yeah.
so individual. Honestly, my biggest thing with FSH is having some core stability first. Because of the weakness of the shoulder girdle, I'm always afraid that without good stability, there may be injuries that occur. And so in general, the generic answer is moderate intensity, meaning the ability to speak whenever you're exercising. However, I think that in regards to exercise for FSH, so you have both of my areas of interest, exercise and FSH, right? There's a study done in the Copenhagen group that they looked at high intensity interval training, and it was quite beneficial for patients with FSH. So it's very different from, say, Duchenne muscular dystrophy, where you're like, don't do strength training and don't do high intensity. This in FSH, I think there is a great potential, and you could talk to your colleagues, your friends and family who actually do exercise. Exercise has been shown to be quite beneficial for individual cases, as well as the research that's out there. I think that's the reason too why many people who have FSH are so motivated by exercise, because they actually see a benefit from it compared to maybe other neuromuscular diseases.
Right. And I will mention that Tina has a great playlist series on our YouTube channel of all the different exercises that she recommends, depending on what severity you are and what you need help with. So visit the YouTube channel. There's a whole playlist just with Dr. Duong.
I wouldn't say a whole playlist. I would say,
well,
it's
close.
a snippet of some of my shoulder the shoulder muscles that you could work on while you're sitting at your desk.
Very good. They're super, super helpful. And so many people in our community have used them. So thank you for doing those. They're very much appreciated. Here's a question that we get a lot, and it's a concerned parent about her son has seen his pulmonologist, but the doctor is adamant that they don't need to worry about pulmonary issues until he's in a wheelchair. So she's concerned, is there anything I can do to send her to make her take this issue more seriously? Because obviously with your presentation, there are concerns.
Yeah, no, absolutely. There's a reference at the end of the deck, and there you can reference the synergy paper with the primary author being Ma et al. In 2018, as well as and I'm sorry if I pronounce the last name wrong, Gosling. There's to the 2018 paper, the 2017 paper that also talks about the decrease in pulmonary function. It doesn't talk about in detail, but if they look at percent predicted, they'll see how different it is. I'm pretty sure in the Ma paper, what I showed you about the MEP muscles, or the respiratory strength muscles that were so declined, I don't think that's in there, but I'm happy to share that if you want to show that to your providers, just for, if anything else, to make sure they monitor you more closely, and then just look for signs of your child having more difficulty, maybe breathing, airway clearance, or even waking up at night and sorry, I'm gonna waking up at night having headaches, or the typical signs that would require a sleep study. So just those things to watch for. It's primarily just to make sure that you're monitoring that, because it's not like the classical form. And because the early onset form is rarer, I think a lot of people kind of put that in the same bucket sometimes. So you have to play the role of being the advocate and the educator, and that unfortunately is the wheelhouse that you have, or the skill set you have to have when having a rarer disease, I think.
Right. And I will just tell this parent too, know that we are recording this session. We'll post it to our YouTube channel, and we will have a blog post with all of the references that Dr. Duong just mentioned. So that will be available to you to take to your doctor when you do go. So thank you for that. A big concern among a lot of our parents, as you can only imagine. We have a concern from a grandparent. Their granddaughter was just recently diagnosed with FSHD, and she has an upcoming appointment with her PT and her OT. Is this who will check the CSS and the MMT? ?
So this is very individual. Not everyone does. If you want the CSS scale, we could definitely send it to you, and I'm sure your clinician could do it. And of course, they can contact me if they have any questions about how to do it. But the manual muscle testing, they definitely can do that. That is in the wheelhouse of occupational and physical therapists. And so if they don't do it, you can definitely ask for it to be done. And I suggest that no matter who you see, make sure there's a set of clinical evaluations that your clinician's following with you every time you come. It may become redundant, but at least then you have your own personal trajectory that you're able to follow. So that you have the outcomes toolbox for yourself or your granddaughter or son that would be helpful to follow long term.
Very good. Man, we are getting a ton of questions. I hope you're up for all of this. Another parent, she kind of heard that about the prognosis for IFSHD, right? Classic FSHD has a pretty normal life expectancy, but is there, I guess, what can she generally expect for life expectancy for her son?
Right. We actually don't know. I think some of the initial studies done in the Netherlands, they found that better standards of care management led to a more autonomous lifestyle and independence. However, we don't have studies looking at long term. So it's hard to know what the life expectancy difference is. I think the key here is that it being a more severe disease, to be on top of other organ systems that may contribute to morbidity, right? So making sure you monitor cardiac, respiratory, so those are not issues that may result in an early loss of life.
Good. But, okay. Very good. And you touched on this earlier. Here's a question. Have you found any link between FSHD progression and physical activity in the cohort? Meaning we may slow down the progression of FSHD while doing adaptive physical exercises.
My bias and also my hypothesis is that physical exercise will contribute to slowing of the progression. Just because I don't know physiologically what it does to FSHD, but what you have on top of FSHD that is a problem is muscle atrophy. I would imagine that without using the muscles throughout the entire range of motion, aspects of the muscle fiber is atrophying, right? And so that results in decreased function. So muscles, brain, use it or lose it type of scenario is very true. And so I think from just a basic physiological perspective that it should, but do we know that from a research perspective? We don't. We just it makes sense from a kind of a physiology perspective.
Very good, very good. Here's a question. I'm not sure if you'll be able to answer this, but with all the therapies being development and the work being done and clinical trials in the pipeline, this question says, if a treatment or cure were to be found, would it work equally as well for the early onset, or do you feel that early onset is going to be more difficult to treat?
Sorry, could you cut out for a bit for me? Could you read that?
Oh, that sure. So if a treatment, were to come onto the market, would it work equally as well for early onset patients, or would early onset be more difficult to treat?
I honestly, I don't know on that one. I can say historically with treatment, the reason why early onset is in a sense a one that people want to look at is that you want to treat earlier and depending on what the treatment is when they're smaller, right? And so that I think the better understanding of the natural history kind of de-risk it for industry, and so that may be I think it's hard to say because it depends on the treatment, right? Whether or not it's be better or worse. I think if anything, it's based on function, how much function you have preserved, more so than early versus late onset.
Great. Okay. I've touched on many of the questions. I know Jamshid, you have some questions for Dr. Duong. Do you want to come on and ask a couple of the questions that you have?
Sure. Happy to ask a couple of questions. Thank you very much for the presentation. It was really comprehensive. You mentioned ceiling effects in a lot of the tests possibly being affected. Would studying juvenile FSH require maybe own set of tools and maybe a different scales, or are the adult onset scales that have been developed and widely used sufficient for this type of research that you're doing?
Yeah, that's a really good question. So that's a reason why on some of these research studies I pointed out the range of scores, because some of these, there's such heterogeneity in this, where you have some people who are so weak they don't score anything on the scale, while you have
Mhm.
people who are so strong they top out on the scale. So I think that that's hard to say. It all depends on what group you're looking at. I think in early onset, there's going to have to be an outcome measure that's different than that may be of the classical form. I mean, then there's other things too. If the patient's ambulatory, you'd have tests that don't have a ceiling, like the time function test, that a lot of other disease groups such as Duchenne correlate how fast you're able to walk to prediction of loss of ambulation or something. We need more studies like that to better understand how these outcome measures correlate to a risk of losing a functional milestone, right? And so I think the short answer is probably yes, but I think we need to spend a little bit more time diving into some of the outcomes that are out there to understand it a little bit better in the different disease cohorts. So you can see in the study by Goslink with the two, peak onsets, you could see even with early, quote unquote early onset, there's two different groups of patients with different trajectories, right? And so you can imagine that there's it's an interesting topic that will probably require some dig diving to figure that out.
Great, thank you. And another question that actually you mentioned, what I wasn't even aware of, that was the comorbidity with cognitive issues, especially epilepsy, being as high as 8%.
Hmm.
I don't know what I guess in the general population, what the prevalence of epilepsy is. But so I was just wondering, is this something that um, it, I guess is only in that very early onset, or even in the adult population? Has it been looked at?
It's primarily an early onset. Epilepsy is not something that is typically seen in the adult onset, and I don't know the prevalence in the normal population, to tell you the truth. But definitely in early onset, it's something that is seen quite a bit more than the classical
And,
form.
and do patients respond well to the standard drug regimen for epilepsy, or do they require different treatments?
Um, that is a good question, and I promise you I will not answer something I don't know. I do not know that answer.
Great. And just coming back to, I think there's still questions popping up from our audience. So I just wanted to ask, for a newly diagnosed juvenile, should the teacher or the school be informed of their condition, especially if it's maybe a little bit on the milder, so maybe they can have different sports routine?
Yep. Absolutely, and not necessarily different sports routines, but there may be different adaptations that are needed. And FSHD Society actually has put out a really nice school, school education. It's online that I'm sure June or Beth or you could send out to the group. But I think that's a really great place to start. I think you should always discuss this with the school, so that you have many people and teachers to be cognizant of what's going on, so they can they may catch some learning difficulties or adaptations that are needed before since you're not there at school with the kids. So definitely yes.
We have published a guide for schools, actually, that
Mhm.
you can give to a child's teacher or their PT teacher or whatever. PE teachers, I suppose. I did post the link to that PDF. It's a downloadable PDF in the chat. So that's something that I think schools should be aware of, definitely.
Yeah. Great. Thanks, Beth.
Sure.
Thank you. Well, I think we're coming up.
Yeah, we are coming up on our time. Do one last question, Jams, or are we good?
I'm fine. There's a lot of questions that were left. You want to take one last one?
Sure. So my friend Anne up in Ontario, Canada has a question, and I don't know if you can speak to the Canadian population or what's going on up there, but she says, of course, the first step is always diagnosis. Do you know which provinces in Canada actually have infantile FSH testing? And if not, is there a way that we could find out and possibly send her that information?
Yeah, sorry, I feel like I'm saying I don't know to a lot of these questions, and I definitely don't know
okay.
about Canada. But I know that Cheryl was she's a PT colleague of mine. She was on earlier, so she may be able to answer that. But I apologize, I don't know about testing in Canada.
All right, and we will follow up with you on that one for sure, because I know it's a big topic. All right. Well, like I said, we're actually over our time just a little bit. I will come back on. Thank you, Jamshid, for helping me manage the questions and for all your great questions as well. Thank you, everyone, for attending our FSHD University webinar today. Special thanks, obviously, to Dr. Tina Duong. Great information, answering all of our questions.
Or not.
Is it okay if folks follow up with you directly with any other questions that might not have been answered?
Yeah,
okay,
please
great.
do. Yep.
Great. Okay. Just have a few notes here that our next monthly FSHDU webinar is on Thursday, March the 18th at the regular time of 1 o'clock Eastern. Our topic is going to be managing difficult emotions and experiences. And our guest is my friend, psychologist, Dr. David Younger. These webinars are scheduled always for the third Thursday of every month from 1 to 2 p.m. Eastern time. So set your calendar accordingly. This coming Tuesday, February the 23rd at 8 o'clock Eastern, 5 o'clock Pacific is our Caregiver Sharegiver Hour. It's specifically for those that are providing care to loved ones with FSH. And of course, our monthly wellness hour is Monday, March the 8th at 5 o'clock Eastern. These sessions are open to anyone, and we discuss a variety of topics, obviously related to well-being. So please join us for those as well. Lastly, our FSHD Society radio show featuring the infamous Tim Hollenbach is the second Tuesday of every month at 9 o'clock Eastern, that's 6 o'clock Pacific. Next month on March 9th, Tim's guest is going to be Carlos Romero. He's a superstar among the FSHD community, and he's actually a national paraclimbing champion. So tune in on, let's see, that's March the 9th at 9 o'clock Eastern. Our radio show is now actually live streaming over YouTube rather than Facebook. So be sure to follow our YouTube channel so you can receive these alerts, both about these live stream events and any other updates. Actually, this one will probably post to YouTube tomorrow, so you can find it there tomorrow. So thank you again, everyone, for joining us today. Thank you again, Dr. Duong, and we will see you next time. Take care, everyone.
Great. Thanks,
okay.
everyone.
Bye. Bye-bye.